Welcome to Aspire Ed Talks. My name is Robert Lowood. I'm joining you from Sydney in Australia. I'm a reproductive endocrinologist here. And I'm really pleased that you joined us on this really important topic. It's called Menopause Management Coming Full Circle. This is a really topical subject at the moment. I think a lot of women are suffering due to lack of treatment and lack of education of the health practitioners. That there was a time some 20 years ago where a lot of people were scared to give HRT. So I'm really, really pleased to have our expert speaker here today, Professor Manolo from the Philippines. She trained at the University of the Philippines College of Medicine and is now the professor there for the Department of Obstetrics and Gynecology. And she has a special interest in many subjects. One of them is menopause management. So thank you for joining us today. I'll start with the first question. What is the perimenopause and the menopause?
Well, thank you for your question, and thank you, everyone, and good morning. Perimenopause would be the years before the menopause. The universal age for menopause is 51 years. And so, there's a study in the Philippines which says that it's about 48 years, and it can vary, but generally we have a universal age of 51 years. So the perimenopause would be the years before the menopause, which can be 10 years before, and the years immediately after the menopause.
So the next question is, what symptoms do patients experience during that period, during the perimenopause?
Well, you can have the vasomotor symptoms. Of course, the hallmark would be your hot flushes. It'd be the night sweats. You can have irritability. You can have headaches. You can have depression, mood swings. Joint pains are very common in Asians. Some would have memory lapses, okay? And, very common among Filipinos would be shoulder pains and joint pains, but the hallmark is really your vasomotor symptoms. Of course, you can have your genitourinary symptoms, the vaginal itching, the discharges, the recurrent urinary tract infections.
Yeah, look, very significant symptoms, obviously. And how long can these symptoms persist for?
Well, they can actually last. Usually they last for about 7 years, and they can be quite severe in about 25% of patients, but they can, in a good third of patients, they can last longer than that. And some people up to age 65, they can still be symptomatic, but generally they would be around about 7 years in duration.
So really quite a long time, isn't it, to have to suffer with those symptoms? And how might one treat these symptoms?
Well, the number one treatment is really menopause hormone therapy. Okay, we used to call it hormone replacement therapy. Now we call it menopausal hormone therapy, which is really the best treatment for all these symptoms, the vasomotor symptoms and the genitourinary symptoms of the menopause. And they can be given. You give estrogen and progesterone in the presence of a uterus, but in the absence, so in surgically menopausal patients, you can just give estrogen.
Mm-hmm. Good. And with regard to the MHT or menopause hormone therapy, what are the potential benefits for the patient?
Okay, so we talk about longevity. So women who take hormone replacement therapy are actually living longer. And the ones who benefit the most are the ones with premature surgical menopause or premature ovarian insufficiency, where you can take your hormone replacement therapy up to the age of 50 or even longer, up to age 60. So you have increasing longevity. Of course, you have a significant reduction in your vasomotor symptoms. There's improvement in sleep. There is improvement in your genitourinary symptoms of the menopause. And if given early enough, within 5 years of the last menstrual period, you can actually have improvement or prevention of your cognitive decline. You have a reduction in osteoporosis and fractures. You have reduction in new onset diabetes. Also the reduction in colorectal cancer.
No, that's very important. And it's important to always note when you're taking something long-term, isn't it? I do remember back when I finished my training just over 20 years ago, there was a big scare into the risks of using MHT from the WHI study, especially with breast cancer. Can you enlighten us in what the evidence is nowadays on the safety of using MHT?
Well, reprisal of WHI data tell us that with estrogen alone therapy, you actually have a reduction in the risk of breast cancer by about 22%. And there is a non-significant increase in breast cancer risk with a combination of estrogen and progestin. That's a 0.28% increase in the risk. And that's considered rare by WHO adverse events standards. That's 1 in 1,200 women years. So that's actually even lower than the risk when you compare it, say, with use of calcium channel blockers, which have been associated with lobular cancer, 2.4, 2.6 fold increase in the risk of breast cancer.
Mm-hmm. Definitely. And is there any time, like if you had someone with breast cancer, would that be contraindicated to use MHT then, or how would you deal with that one?
So yes, so we have to know what are the contraindications to hormone therapy. We obviously can't give it to all patients. We can't give it to patients with breast cancer, with hormone-dependent cancers like endometrial cancer, patient who's had a thrombotic episode like venous thromboembolism, or deep vein thrombosis, myocardial infarction, stroke. So these would be major contraindications. Of course, patients can still be pregnant at this in the perimenopause, so that's a contraindication. And also patients with undiagnosed vaginal bleeding. So these are very well-known contraindications. So we should not be giving hormone therapy in these women.
Okay, perfect. And what modalities exist in using MHT sort of thing? How can we administer that to the patient?
Right. So that's a very good question. So we usually give them orally. So we give oral estrogen and we give oral progesterone. But we also can give transdermal forms of estrogen. So for the oral, we give usually for the early menopausal patients, like 2 milligrams of estradiol valerate. And for patients who don't mind the menstruation, so patients in the perimenopause can be given like progesterone, like your dydrogesterone or your micronized progesterone, and you give it for 1 to 12 days every month, and then they would expect some withdrawal bleeding. For some patients who don't really want to menstruate, then you can give the 100 milligrams of micronized progesterone on a daily basis, together with your estrogen, the 2 milligrams. Now, we do have safer forms like the transdermal forms because they bypass the liver, and in the process you obviate the risk of thrombosis. And so you have the transdermal estrogens, which are given on a daily basis, and you give the micronized progesterone or your dydrogesterone. These are the progesterone supplementations available.
Mm-hmm. Good. No, definitely lots of options. So if you had a 45-year-old patient who is suffering from menopause symptoms and her periods are quite irregular, what would be your preferred treatment option in that patient?
Okay, that's a very good question because a 45-year-old still has a potential to get pregnant. So if she's not desirous of pregnancy, you can even give oral contraceptive pills. So that will provide you the estrogen that she needs. Also, will give you the progesterone, so she will have monthly menstruation, and so you can tide her over from 45 to the age of a natural menopause, which would be 51, and then you can shift her to hormone replacement therapy thereafter. Or at this point, you can also safely put her on the estrogen and progesterone combination of your MHT, whether it's transdermal or oral, that should be okay. The risk of a stroke would not be so high at this time unless your patient has metabolic syndrome or hypertension, in which case you would go for the transdermal forms of your MHT. But of course, she has to be practicing some form of contraception at this time.
Mm-hmm. Good. And with things like high blood pressure, hypertension, there was always this scare about using HRT. If they're treated well, do you think it's safe to give them menopause hormone therapy?
Definitely. So for patients with controlled blood pressures, controlled blood sugars, then you can safely give your HRT. Okay, so that should not be a contraindication. Of course, any patient with uncontrolled hypertension would really have to, you really have to take care of that because with or without the MHT, sorry about that.
Yeah, that's good. No.
Yeah, so any patient with uncontrolled hypertension would obviously be at risk of a stroke, of a heart attack, or MI. So obviously, these patients should not be given anything at this point. You should be controlling their blood pressures first.
Mm-hmm. No, definitely, that's very important. That's a really good answer to, a difficult clinical scenario. And look, finally, if someone's on MHT and like, how often would you review them, and is there time you would maybe consider stopping the medication?
Yeah, that's a very good question. We used to say that we were supposed to be giving MHT only for 5 years because there were some literature saying that you increase the risk of breast cancer beyond 5 years of MHT use. But, you can give your MHT for so long as the patient needs it. Okay, so you see your patient, you check your patient. If she has the symptoms, if she has the indications, what will be the indications? She has moderate to severe vasomotor instability. She has genitourinary syndrome, or maybe she's even at risk. On top of that, she's at risk of early onset heart disease or osteoporosis and fractures. So these would be the patients who would benefit the most from MHT. And of course, you do your baseline examination of your patient, your pap smear, mammogram, make sure that there's no breast cancer lurking there somewhere. And you can probably do your biochemical, your lipid profile, just to see you want to have a baseline. And of course, if there's hypertension, you control the hypertension. If there's diabetes, you make sure that the sugar is well controlled. And you can see the patient maybe a month after, just to see how she's doing with her hormone treatment, if she's taking it properly, if there's beginning reduction in the symptomatology. And then you generally have to see your patients every 6 months. And make sure that they don't develop any contraindications to the treatment, and see if they're improving. I mean, if there's no improvement, they're probably suffering from something else, and MHT may not be the answer to their problem. But for the answer to how long can you give it for, the answer to that is for so long as the patient needs it.
Okay, really, really good advice. Look, thank you so much for all that advice about how to treat the menopause, the symptoms. And as I said, it's such an important topic at the moment because a lot of women suffering without enough adequate medical help. So thank you so much for that. And thank you for joining us for Aspire Ed Talks. And we hope to see you at another podcast again soon. Thank you.
Thank you. Thank you very much for having me.
Pleasure. Thank you.